Good morning. I am Dr. Venila, Department of Periodontics, Vivekananda Dental College for Women. Today we are going to see about flap techniques and types of incision. Periodontal flap is the most common type of flap used in periodontal surgery or oral cavity. So it's defined as section of gingiva or mucosa that is surgically separated from the underlying tissue to provide visibility and access to the bone and root surface. What is the rationale? Rationale is the removal of root surface noxious agent, inflamed tissue, and to have ideal gingival and bone morphology without sacrificing investing and supporting tissues and compromising aesthetics. For periodontal surgery, we need incisions. Periodontal flaps involves two types of incision. One is horizontal, that is mesiodistal, vertical from occlusal to apical incision. So in horizontal incision, we have three types of incision. One is internal bevel and clavicular incision, then followed by interdental incision. For incision, we need armamentarium, a BP handle and 15 blade. So first incision is internal bevel incision. It starts at a distance from the gingival margin and aimed at bone crest. This is the internal bevel incision. Followed by clavicular incision. It starts at the bottom of the pocket and directed to the gingival margin. Then internal bevel incision is the most common incision. So vertical incision starts at the gingival line angle, that is a tooth line angle, and directed toward the base, that is up to the alveolar mucosa or mucogingival line. The base should be broad for the vertical incision. Then followed by interdental incision, that is one type of adult incision. It placed on the interdental area, this side and this side. So this flap surgery is where it is indicated. So presence of persistent, moderate to deep pocket, that is more than 5 mm, and presence of osseous defect, presence of inflammation and disease activity at the base of the sulcus seen by bleeding and probing, furcation involvement to regenerate periodontal tissue by the use of bone graft, gingival oval growth and asymmetry, the periodontal pocket adjacent to distal molars, and other dental procedures such as crown lengthening and apexectomy. So first picture shows the pocket depth, presence of pocket depth. So next picture shows presence of osseous defect. So next picture shows bleeding and probing at the base of the pocket. Then grade 2 furcation involvement in maxillary molars. This is drug induced enlargement. We need modified Widman flap. So distal molar pocket. So these are the some of the indication for the periodontal surgery. So where it is contraindicated. So optimal results can be obtained by non-surgical periodontal therapy itself. The surgery is not needed. Then unprepared and soft edematous gingival tissue. Then medically compromised patient where surgery is risky posture, where diabetic uncontrolled diabetic mellitus and cardiovascular disease. The patient presenting consistently with poor oral hygiene who are non-compliant. So tooth with hopeless prognosis that is not able to preserve, that is grade 3 mobility and grade 4 furcation. Then when surgery is likely to result in extreme aesthetic disfigurement. These are the areas that the flap surgery is contraindicated. So types of flap. The flap will be classified into three different exposure. One is bone exposure after flap reflection. Another one is placement of flap after surgery. Then another one is management of interdent papilla. Depending upon the bone exposure, it is classified into full thickness and partial thickness. Full thickness is otherwise known as mucoperiosteal and partial thickness is otherwise known as split thickness. So another classification is placement of flap after periodontal surgery. So that is displaced or undisplaced flap, not displaced or displaced flap. Then management of papilla. Depending upon the management of papilla, it is classified into conventional flap and papilla preservation flap. Full thickness flap means all the soft tissue including the perforation is reflected to expose the bone. So it all includes soft tissue along with all that is full thickness flap. Now coming to the partial thickness flap, it involves only epithelium, layer of only outer epithelium and the layer of connective tissue, that is split thickness flap. Next classification, flap placement after surgery. So after surgical procedure, after elevation, where you have placed the flap after elevation, whether you have placed on the same position on the before the placement of the surgery, or slightly apical or coronal. Apical means toward the root surface, coronal means towards the crown surface. This is another type of classification. Then next, depending upon the management of interdental papilla, we have two types, papilla preservation and conventional. Conventional flap involves only two incision. One incision is clavicle incision followed by interdental incision. That is normal conventional flap. Okay. So for papilla preservation flap, you have to preserve the papilla. So the papilla will not be cut. So the incision will be either placed on the palatal side or the buccal side. Now I placing the incision on the J shape or round shape incision on the palatal side. Then papilla is completely elevated and via interdental, usually indicated in broader interdental spaces. So via interdental space, the full papilla is converted, coming to that of buccal side. So either palatal side or buccal side, the complete papilla will be eliminated. That is called papilla preservation flap. After the incision, full thickness periosteal flap is elevated for regeneration of osseous defect. So for using, we are periosteal elevated, Holmes periosteal elevated. This is conversion of flap side into, this is one side, this is another side, this is a blunt side, this is a sharp side. So by using blunt after incision, blunt side, you have to elevate the full thickness flap in order to visualize the osseous defect. After the flap reflection, the process of debridement is begin. We have to remove the granulation tissues by sharp greasy curettes. Once the bleeding stops, then we have to view the surgical fluid and the calculus will be removed by either means of hand scalers or curettes or ultrasonic scalers. After debridement, osseous defect is corrected by means of regenerative using bone graft or resective by means of bone vials. Then flap will be approximated by sutures and suturing techniques. So sutures and suturing technique will be seen in next video. Thank you.